We are live in 5, 4, 3, 2, 1. We are live now.
So welcome to this
Ma'am,
session.
you can start.
Yeah, ma'am will start. I'll just introduce the thing. So welcome to the session on meniscal injuries from Dr. Malini, and I'll just invite her to share her presentation. Over to you.
Thank you, Dr. Ashok. So I think last session we had a discussion on the...
Ma'am, we cannot hear you.
Not here.
We can hear you.
Am I audible?
Yes, you are audible.
Yeah, okay. So I think last week we had a good discussion about imaging of ligament injuries, and continuing with that, now this time we'll look at menisci. The format would be similar. We'll look at... We'll always begin with how does a normal meniscus look, because that is very important to understand how a normal meniscus looks so that we can detect what is abnormal. After that, the million-dollar question, is there a tear or not? And how do we answer that? If there is a tear, can we classify it further? What is the type of tear? How can we identify that? What is the information that is important to help in the management, which is the whole purpose of an imaging, to give the information which can help decide the management? How can we do that by MRI? And lastly, is it really a tear, or is it something which one is getting confused? It's a pitfall and not really a tear. So this is the sequence that we'll follow and look at in today's presentation. Menisci, as we all know, are C-shaped fibrocartilaginous structures. They have an anterior root, posterior root attachments, anterior horn, posterior horn, and the body. And on a cross section, it looks like a triangular appearance with the periphery being thickened and the central portion being more tapered. And we all know the microstructure of the meniscus, where there are these circumferential fibers marked in red along the periphery, and the radial fibers marked in green going from the center outwards. And that is the reason the longitudinal tears are more common peripherally, while the radial tears are more common in the inner portion. Which are the sequences that we look at when we look at menisci? So the most important sequences are 3 plane proton density images, which shows the meniscus well, in conjunction with fat sat T2-ated image. It's very important to have a fat saturated T2-ated image and not just a fat saturated proton density image. So this is a proton density image, sagittal, axial, sagittal, coronal, and axial, and then a sagittal fat saturated T2-ated image. This helps us to look at fluid signal intensity within the meniscus, which would be seen with a tear. Let's start looking at the normal anatomy. How is a normal meniscus seen on the proton density images? Let's begin with the sagittal sequence. So this is, since you all are well versed with the meniscus looking like this, we just have to now imagine how it looks when a section is passing through it on MRI. So let's begin with the sagittal image. A sagittal image which is passing through the body of the medial meniscus, you can see the meniscus as a bow tie-like appearance. Fibrocartilage looks dark on all MR sequences, T1, T2, proton density, all sequences. Fibrocartilage looks dark. This is because the tissue is the fibers are so tightly packed that there is no place for the water molecules to move around. So they do not give out signal. Whenever there is an abnormality which allows movement of water molecule or fluid to enter, that will give out a bright signal. But a normal meniscus body shows a bow tie-like appearance, which is dark on all the sequences. As we come more inwards, we can now see the medial meniscus, the anterior horn, which we can outline here. And this is the posterior horn. Further, we can see the anterior horn is smaller. In medial meniscus, the posterior horn is 1.5 to 2 times the size of the anterior horn. So remember that meniscal pathologies are not only abnormal signal, they can also be abnormal morphology. So it's very important to keep in mind the normal appearance. If the posterior horn of medial meniscus becomes same size as the anterior horn or smaller, then that is abnormal, even though it may look dark and triangular. Again, we can see here, this is the anterior root where it is attaching to the tibia almost. And this is the posterior horn, which normally shows a sharply angulated triangular appearance. And this is the apex or the inner free margin. This here is the posterior root of medial meniscus. And that should be seen at the level where you see the posterior cruciate ligament. If you do not see the root up to that level on the sagittal image, there is abnormality, a root tear. As we come further laterally, you can see the posterior cruciate ligament, and you can just see the posterior root of the medial meniscus attaching here. As we come laterally, now you can start seeing the lateral meniscus posterior horn. This is the anterior root of lateral meniscus, which normally can show some striated appearance, some bright signal, which is normal. As we come further laterally, we can see anterior horn of the lateral meniscus, posterior horn of the lateral meniscus, both of which are almost equal in size. Further, we can still see the anterior horn and the posterior horn of the lateral meniscus. Further, we start seeing the body of the lateral meniscus, which again looks like a bow tie appearance. And because of the thickness of the meniscus, normal thickness, this bow tie appearance should be seen in about 2 sections or so on the sagittal images. This here is the Popliteus tendon. And you can see this is the Popliteus tendon here. And these lines which I drew are the popliteomeniscal fascicles, the superior and the inferior popliteomeniscal fascicles. As we come further peripherally, you can again see the bow tie appearance of the body of lateral meniscus. So that's the anatomy on the sagittal images. Now let's look at anatomy on the coronal images. So this image here tells you where the MR section is passing through. So now this here is the medial meniscus posterior horn. And it's dipping down here, which is its root attachment. This here is the posterior horn of the lateral meniscus. This here is the Popliteus tendon, and these are the popliteomeniscal fascicles. As we come further anteriorly, you still have the posterior horn of the medial meniscus. So now, as you can see, it's cutting through this whole section. It looks like this, and this is the root attachment where it dips and attaches to the tibia. While this is the lateral meniscus and its root attachment, posterior horn of lateral meniscus. This here is the Popliteus tendon, and these are the popliteomeniscal fascicles. As we come further anteriorly, you can see the posterior horn body junction of the medial meniscus, of the lateral meniscus, and this here is the popliteal tendon. This here is the fibular collateral ligament. So Popliteus tendon is very closely associated to the posterior horn of the lateral meniscus. Now we start seeing the bodies of the menisci. This here is the body of the medial meniscus, which is seen as a triangular, sharply marginated dark triangle. This is the body of the lateral meniscus. This here is the medial collateral ligament, which is closely attached to the medial meniscus. As we go further ahead, we can still see the body of the medial meniscus, while we can now see the anterior horn of the lateral meniscus, and this is the anterior root attachment, which I told you can look slightly bright. That is normal. Furthermore, anteriorly, this is the anterior horn of the medial meniscus with its root attachment. So on sagittal images, the posterior horns of the horns of the menisci look triangular. Body looks bow tie or slab-like. On coronal images, the posterior and anterior horns look slab or bow tie-like, while the bodies look triangular. Axial images we do not use to interpret for tear. We use it as a sequence which confirms what we see on sagittal and coronal images. So we are primarily looking at coronal and sagittal images, and then we look at axial images only to confirm the findings, because it's not always possible that the menisci may be seen on one section. There may be averaging, so we do not look at axial images primarily. But yes, it helps us to look at root tears, at radial tears, we'll look at them. So a few important points to remember. On a sagittal images, the bow tie appearance of the body of menisci should be seen in about 2 to 3 slices. Posterior horn of medial meniscus is always larger than the anterior horn. The posterior root of medial meniscus reaches on sagittal images up to the section where you see the posterior cruciate ligament. If any of this is not happening, then there is something wrong. We can also look at the meniscus, the red zone, which is the peripheral third, the red, white, or the pink zone, which is just inner to it, and the larger white zone. So again, this will make a difference to the management. So when looking for tear, we want to look at is the tear in the red zone, because then it is amenable to repair, or if they are very small, they may heal on their own, as this being the vascular zone. While if it is in this white zone, which is avascular, repair is not possible. So having looked at how meniscus is seen normal on a normal scan, a normal meniscus, let's look at abnormalities. So the question is there a tear? A normal meniscus, we already discussed, looks dark triangle like this because it is normal fibrocartilage. There is not much place for the water molecules to move around, the hydrogen protons to move around. If you start seeing globular signal, hyperintense signal, that is grade 1 signal, which is intrasubstance degeneration. If you see linear hyperintense signal, like we can see here, that is grade 2 signal, which could be due to intrasubstance degeneration within the middle perforating bundle, and it does not reach the articular surface. You may very often see this kind of a linear hyperintensity within the meniscus going from the periphery inwards, not reaching the articular surface. By articular surface, we mean the superior surface, the inferior surface, and the inner free margin. This posterior margin is not counted. Any of these superior or inner articular surfaces or this apex. If the signal reaches there, then it is abnormal. If the signal here, like this, that is again a grade 2 signal, which is often due to a prominent vascular pedicle. So we see this more often in young children and young adults and children. So this is signal. Now the problem occurs when people start labeling this as grade 2 tear. There's nothing called as grade 1 tear or grade 2 tear. It is grade 1 signal, which is nothing but intrasubstance degeneration. Or it is grade 2 signal, linear signal, linear bright signal not reaching articular surface, which is not a tear. It could be due to intrasubstance degeneration, or it could be seen due to a prominent vascular pedicle. Grade 3 signal is a tear. So tear does not have grades. You don't have a grade 1 tear, grade 2 tear. When there is a grade 3 signal, that means there is a tear. How do we see that? You see this as bright signal intensity, linear, which without any doubt is reaching the articular surface. Here it is reaching the inferior articular surface. Here you can see it is reaching both superior as well as the inferior articular surface. So unequivocally, linear bright signal in the meniscus reaching articular surface is a tear. If you have to think too much, is it reaching or is it not reaching? Then probably it's not reaching. Also make sure you look at the signal on multiple planes, on the sagittal as well as the coronal, to confirm it is or it is not reaching the articular surface. So when we want to look for meniscal tears, we are looking at abnormal morphology as well as abnormal signal. Signal we discussed, it can be grade 1 signal, grade 2 signal, and grade 3 signal. The grade 3 signal is what is a tear. Abnormal morphology, we already discussed how a normal meniscus shape should be. If the shape is altered, if the meniscus looks smaller than what it usually should, then it is abnormal. So now we looked at how a normal meniscus looks on MR. We discussed how exactly do we identify abnormal signal within the meniscus. When is it really a tear? And now we come to the next section. What is the type of tear? Can MR help us identify it? Yes. So if we look at the cross section of the meniscus, you may have a tear which splits the meniscus into a superior and an inferior portion. That is a horizontal tear. Or it may split the meniscus vertically, which could be a vertical tear. Let's look at how do we identify these. Horizontal tear will be a tear in this fashion. It will be splitting the meniscus into a superior portion and an inferior portion. And that's exactly what we see on MR. This is the normal anterior horn of the medial meniscus. And here you can see this is the posterior horn of the medial meniscus. And you can see this linear bright signal reaching the articular surface inferiorly, and there is an associated small parameniscal cyst because of synovial fluid going into it but not coming out due to a ball valve mechanism. Again, here you can see a horizontal cleavage tear and you have this parameniscal cyst. These cysts can be very large at times and could be the cause of symptoms due to pressure effect. So whenever you see a cystic lesion just adjoining the meniscus, you can look carefully at it and trace it to the tear. Next, coming to longitudinal tears. How do longitudinal tears look? They are in the peripheral third of the meniscus, normally in the vertical plane. So if we look from the surface, this is how the longitudinal tear will go. It will follow the shape of the meniscus in the peripheral portion. And this is what we see here. This whole thing is the meniscus. And you can clearly see this cleft-like bright signal in the peripheral third reaching superior and inferior articular surface. Again here, you can see this cleft-like in the peripheral third. And these are the ones in the red zone peripheral, which are amenable to repair, or if very small, may heal on their own also. So you can clearly see here a longitudinal tear in the peripheral portion of the meniscus, peripheral third, reaching superior and inferior articular surface. And as we go on the sagittal images, subsequent sections, you can see the distance from the periphery of the meniscus is maintained. So it's taking the shape of the meniscus as we saw here. A particular type of longitudinal tear is a bucket handle tear, which involves a much larger area, more than 2/3 of the meniscus. And because this longitudinal tear is so large, this fragment has got displaced into the intercondylar region, forming what looks like a bucket and its handle. How do we identify it on MR? So on a sagittal image, normally you should see the bow tie appearance of the body in about 2 to 3 slices because this meniscus is that thick. But here, because of the bucket handle fragment, it has become thin. So I start seeing something looking like a bow tie, but immediately next section, these are consecutive images. There is no bow tie appearance at all. You can see the anterior and the posterior horn. And here it looks almost like there are 2 anterior horns because that is this fragment out here. And as we come where the posterior cruciate ligament is, it looks like there is another posterior cruciate ligament, double posterior cruciate ligament appearance, but that is this fragment. Because you are cutting this fragment in this section, you are seeing it, it looks like a double PCL appearance. On coronal images, how do we see? On a section like this, you should see only the body of the meniscus. But here, in addition to the body, you start seeing this fragment in the intercondylar region. So this here is the body and this is the fragment. So you can see this body, instead of being normal triangular, it is blunted. You don't have the inner portion, and that inner portion is located here in the intercondylar region. Further, this is the normal body of lateral meniscus. Medial meniscus, you can see an attenuated body and this fragment here in the intercondylar region. Again, body, and here you have the displaced fragment. On axial images, how can you see them? This is the meniscus. Here it is thinned out, it is attenuated, and you can see this whole component which has come here. The problem with axial images, you may not always get an image like this where meniscus is seen in one section. So that's why axial images are not primarily useful. We use them only to confirm what we see on sagittal and coronal images. Another example, bucket handle tear. You can see here what looks like two anterior horns. So it's called as double delta appearance. And then you can see it comes here, this portion, and elongates. So this is the whole intercondylar fragment. Coronal images, again, this is the displaced intercondylar fragment, and the body here has to be smaller in size. Double bucket handle tear, in addition to the displaced fragment, there's additional tear in the peripheral component. So this is the displaced meniscal component in the intercondylar region. And here in this peripheral remnant, you can see additional longitudinal tear. So this is a double bucket handle tear. So imaging wise, the information that we can give is how much intercondylar, what is the size of this fragment, and what is the remnant. So is it through the red zone, and then that is something which is can be repaired, or is this remnant too small, or is it attenuated? There is additional tear which may not allow repair. So we looked at horizontal tear and we looked at longitudinal tears. Next, coming to radial tear. Radial tear, as we know, is a vertical tear which extends from the inner margin peripherally. It may involve a small portion, or sometimes it can even be full thickness when the meniscus will completely lose its hoop strength. Now, how do we see this radial tear? So imagine a section passing through the meniscus like this, and there's a radial tear. You see a small cleft. So this tear is very common at the junction of anterior horn and body of lateral meniscus because of a smaller radius of curvature of lateral meniscus. So you can see this here, the small cleft-like appearance. That is a radial tear. How do we see it on the coronal images? Again, you can see this small cleft-like appearance. Radial image, if you can see the meniscus here. So posterior horn is not included in this section. It has not been covered because, as I said, it may not come in one section. This is the meniscus, and you can clearly see this radial tear here. So axial images help us to confirm what we are seeing on sagittal and coronal. Radial tears are the most subtle ones, and they are very, very easy to miss because they are involving the inner third. They can be very small. So one has to be careful to look for these. And here you can see it may be seen just as a cleft. So you need to have thin sections, about 2 to 3 millimeter thick sections for MRI, not larger than that, because then you may miss these small radial tears. So these are the most easily missed tears. It may be seen as a truncated triangle. The inner portion is not visualized. For example, here, this is a normal triangle, and here you can see this is truncated. So it can be a subtle finding. Again, a very small finding, which is the cleft here, which looks as if this posterior portion is elongated, but this is a radial tear out here. Another example of radial tear, normal body of meniscus. Here you can see it is significantly truncated. See this defect out here. On the axial images, you can see this is the meniscus, the black appearing one. And you can see this is the radial tear out here. A particular type of radial tear is the root tear. And this is most commonly at the posterior root attachment of the medial meniscus. So I showed you how the medial meniscus normal should dip down and attach to the meniscus, while here you can see this full thickness defect, and that's a root tear. So you have a tear at the attachment of the meniscus to the tibia. On the sagittal images, I said that the posterior horn of medial meniscus should reach up to the level where you see the posterior cruciate ligament. But here you are not seeing any medial meniscus. So that is abnormal. It's a root tear. How does MR help in management in these patients? We need to talk about the cartilage. So for example, in this patient, the cartilage is well maintained. Extrusion, we'll have to see the additional sequences. In this patient, if you see, again, there is a root tear. This is the posterior horn of the medial meniscus, and you can see this defect out here. It's a root tear. But what we also see is this cartilage is very bad. Tibial cartilage is thinned, and femoral cartilage, there is high-grade cartilage loss. Also, this meniscus is extruded. So if the meniscus is extruded, if there is cartilage loss, a root repair will not be done. But if the cartilage is relatively maintained and there is not much of extrusion, one can go in for a root repair. So that's how all these findings together give information which can help plan the management. A peripheral third red zone longitudinal tear can be repaired. A radial tear or a tear involving the inner portion of the meniscus, a horizontal cleavage tear, one may do only partial meniscectomy. If there is a parameniscal cyst, that also needs to be dealt with, because otherwise that itself can cause pressure effect, mass effect, and lead to symptoms. Oblique tear. So oblique tear has multiple names. I'm sorry. Yeah. So an oblique tear can be called parrot beak tear, flap tear. It begins as a radial tear and then it becomes longitude. And this leads to this portion here, a flap, which initially may not be displaced, but later this gets displaced as a flap into a different location. So that's the term that we usually use is an oblique tear. Flap tear, parrot beak tears are the other words for it. How do we see it? It's seen as a bright signal reaching articular surface. But now if you see, unlike a horizontal cleavage tear, this inferior portion is blunted. So that's an oblique tear. And if there is a displaced flap, here in this patient, you can see here, this body here is attenuated. Body of lateral meniscus is normal. Body of medial meniscus is attenuated. Whenever a meniscus looks smaller, abnormal morphology, look for a displaced flap. And you can see this displaced flap in the superior medial gutter. Again here, this meniscus body, you see a large defect, and you see this displaced meniscal flap in the superior medial gutter. Other common location where a flap may be seen, either it may be superior or inferior gutters, or again, you can see this large defect, and this flap is seen here near the posterior root attachment. Axial images show you this defect, the parrot beak tear or a flap tear, and you can see this flap here, the displaced meniscal flap. So again, it's very important to identify these flaps so that during surgery, these can be removed. So it's important to mention the location of these lesions, because then one can know where these flaps are displaced. Another type of tear is the ramp lesion, which is at the posterior meniscocapsular junction of the medial meniscus, or it could be the peripheral most portion of the medial meniscus. So normally you don't see a fluid intensity cleft, as you can see here. This patient has got an anterior cruciate ligament tear, as we can see here. I think Dr. Aditya discussed this in detail last time. While here, if you see the anterior horn of medial meniscus, posterior horn of medial meniscus, there's marrow edema, marrow contusion here. And there's a clear fluid signal intensity at its attachment to the capsule. So this is a ramp lesion. Again, these can be subtle. So the tears which are subtle are the radial tears, ramp lesions, and displaced flaps. So those flaps may be small and one may be missing them and not seeing them unless you look for them very carefully on all the sequences. A complex tear is one which shows multiple branching pattern. Here you have horizontal as well as vertical component reaching superior as well as inferior articular surface. So they say that the signs of an unstable tear on MR is a size larger than a centimeter, complex pattern, displaced flaps. All of these suggest an unstable tear. Next, coming to discoid meniscus. Unlike a normal meniscus, a discoid meniscus developmentally has a more pancake-like appearance, and that's what we see on MR. This is the normal body of medial meniscus, while this body of lateral meniscus you can see so much larger, occupying the entire joint cavity. So this is a complete discoid meniscus. You may have partial discoid meniscus, which could be smaller than this, but larger than the body of the other side. Normally, the bodies of the medial and lateral menisci are of the same size. But here you can see it is much larger. It is showing intra-substance, hyperintense signal, bright signal. These are more prone to degeneration because of their abnormal shape. Sagittal images, the same patient, you can see this discoid meniscus, it's reaching all the way. This is another patient, sorry. On the coronal images, it's reaching all the way to the intercondylar region. There's a tear with a parameniscal cyst. So discoid menisci, even intra-substance signal can be significantly symptomatic. Now, we looked at how normal meniscus looks. We looked at tear. How do we identify? We looked at the different types of tears. And we also looked at how the information on MR can help us plan the management. What is the status of the cartilage? What is there a displaced flap? Now, the next question comes, is it really a tear? Can we be wrong when we call it a tear? So yes, false negative. As I said, radial tears can be very subtle. Also subtle tears of peripheral posterior horn, like I said. Again, these can be subtle and we may be missing it on MR. False positive, when we radiologists say there's a tear, but you come back saying, no, there's no tear. Very often it is normal structures and variants which can be confused. Sometimes it could be due to incomplete arthroscopic evaluation. You may have these tears in hard to reach areas, or a flap may be displaced in a location which may be difficult to, unless you're looking for it. And I think the main thing is the terminology is used. Often people end up saying a grade 2 tear, which doesn't mean a tear, because on arthroscopy you're not going to see it. It's grade 2 signal, that's all. It's not a tear. And an article talks that most of the interpretation errors are due to normal variants. Some are due to equivocal MRI findings, something that one may feel grade 2 signal, other may feel grade 3 signal. And there are certain unavoidable errors which may be due to, we need to be aware of these normal variants. And that's what we are going to look at. We start looking at this anterior horn of lateral meniscus. These are subsequent images. Is this a tear here? This is normal posterior horn. Is this a tear here? Looks like. But whenever you feel something is a tear, trace it. So keep looking at this structure. When I trace it, it goes all the way across in the intercondylar region to the opposite side and then fuses here with the anterior horn. So this is nothing but the transverse meniscal ligament, which joins the anterior horns of the two menisci. Now, in the same patient, I start looking at this. Is this a tear of the posterior horn of lateral meniscus? Could be. But when I think something is a tear, I need to trace it. Can you see the structure going behind the posterior cruciate ligament? So that's the ligament of Risberg. And then you can see it joining attaching to the medial femoral condyle. So whenever something looks like a tear, make sure it's not a normal structure. Here again, another example. Is this tear of posterior horn of lateral meniscus? Maybe, but I trace that dark structure. It goes behind the posterior cruciate ligament and attaches to the medial femoral condyle. So this is the meniscofemoral ligament of Risberg. Similarly, you may have a ligament of Humphrey. You can see this small structure here. So again, if you trace it, you know that it is a normal ligament. This may be of different sizes in different people, may be quite prominent in some. Similarly, you may have an oblique meniscal ligament going from posterior horn of one meniscus to the anterior horn of the other meniscus. So for example, if we just start looking at this, look at this posterior horn of the lateral meniscus, okay? You can see this black structure coming here. Is that a bucket handle tear fragment? But then the body is normal in size. And then you can see it coming all the way up to the anterior horn of the other meniscus. Popliteus tendon, at times, is this a tear in the meniscus, lateral meniscus? But trace it. Note that it is going down here. You can trace it all the way to the muscle. This is popliteus tendon. While lateral meniscal longitudinal tears are usually the opposite direction. Popliteus tendon goes posteriorly, inferiorly. So this cleft here also goes posteriorly. While the tear, the cleft goes anterior. Sometimes you see something like this and you wonder, is this a bucket handle tear? But that's nothing but the root. The root, because it's a C shape, it is curving inwards. So then it's only seen in one section and the body is completely normal. And sometimes you may have a meniscal flounce. The meniscal may look a little wavy. So that's just a normal variant-like appearance and not a tear. So if we look at a checklist for meniscus, first, is there really a tear? I think most important. Followed by, what is the type of tear? Horizontal, longitudinal, bucket handle, radial, complex, root tear. What is the location of the tear? Is it in the anterior horn going into the body, or is it at the posterior horn body junction? Is it in the red zone, the peripheral third, or in the inner portion? Are there any displaced meniscal flaps or fragments? How is the meniscus itself? Is it degenerated? Because if you have a degenerated posterior root tear with cartilage loss and extrusion, a root repair is not indicated. But if the meniscus looks good, there is not much of extrusion and the cartilage is maintained, then yes, root repair is possible. So always this is a checklist we need to keep in mind while reporting a meniscus so that we know that all these findings have been looked at. So that is about the menisci. We will go through few cases, but at this point itself, I would like, before I show the cases, if there are any questions, I would be happy to answer, and then we can go ahead and just go through few cases. Yeah, I can see questions here, so I can answer. How to see lateral meniscus root tear? So it's the same. Lateral meniscus root tears on the sagittal images look to the root going up to the tibia, going up to the posterior cruciate ligament level. Also on the axial images and coronal images. So the normal anatomy that I described, that is what you will be looking at and look for defects in it. What is the slice thickness between consecutive sections on sagittal and coronal images? So different people do different slice thickness. It all depends on the machine. Because if one has a lower field strength machine, then if you take very thin slices, the images may get grainy. And also depends on the coil that you have. So two things. One is the magnet strength and one is the type of coil. If you have a dedicated coil, even with a lower magnet field strength, you will get better image. So we try to get 2 to 3 millimeter, not more than that. And the gap between the slices ideally should be 0, but up to 1 is okay. So 2 or 3 millimeter thickness with 0 or 1 millimeter gap between them, nothing more than that, because then you'll high chances of missing the tears. What is double ACL sign? So we see these signs, we have a double PCL sign, not ACL. Double PCL sign is seen in bucket handle tear. The intercondylar fragment lies in the same section as the PCL. So it looks like there are two posterior cruciate ligament, but it is the intercondylar fragment which has come from the body of the meniscus. What is ghost sign in meniscus? Ghost sign is in a radial tear, when there is a full thickness radial tear and the sagittal section or coronal section passes through the tear exactly. You don't see any meniscus at all. So you see meniscus in one section, no meniscus, again meniscus. That is a radial tear. How to differentiate between radial and longitudinal tear? Maybe I can just show in the cases. I'll just show it in the cases when we come to that. A complex flap degenerative tear in wide zone of the meniscus with cartilage involvement needs excision. Probably that would be a question for all of you to discuss and answer. But yes, if it is an inner one, repair will not be possible. Benefit of having 3 Tesla imaging. So yes, 3 Tesla does show the tear better, but I don't think 1.5 Tesla will also miss any tear if you obtain good resolution images. So for cartilage, yes, 3T makes a difference, but I don't think we can, for a tear, obviously 3T will show it better, but not necessary. Any specific findings for healed or healing meniscus? So this is a little difficult issue, because what happens is post meniscus repair, the signal intensity within the meniscus still persists, and that on MR to us looks like a tear itself. So for that, one clue is we look on T2 weighted image. Is it really fluid signal intensity? Because otherwise we are looking at proton density also. But here we look at T2 weighted image. Is it really like fluid signal intensity? Then it is a tear. Otherwise it's not. Some people do arthrograms to see if contrast is going in there. In our practice, we do not really use it. But yes, that is a pitfall which one has to be careful about. In sagittal section, is it always whole body of any meniscus? Never seen. So in the sagittal section, in the peripheral most portion, you will see the body as a bow tie appearance. Where to look for flap? So the 2 most common places which I showed you are in the gutters, the superior or the inferior medial gutter, and near the posterior root. These are the 2 most common places where we see the flap. And with sections, usually coronal sections show you these, but you will also look on sagittal. So on imaging, it's not any one section. We look at all the planes equally. Post-hoc meniscus repair images, I did not include that, but I can just show you some towards the end. Software to use to see the MRI on computers. So what we use, basically our images are all DICOM images. So you need any kind of a DICOM viewer. There are some free ones available like K-Pack, Radiant Viewer, some are free available and others are paid. So these are basically DICOM viewers into which you can import the DICOM images. Okay, so I think I have answered all the questions here at least. So we can proceed with the cases. Let's just go through a few cases so that we can kind of look at what we saw. Yeah. Is my screen visible?
Yes.
Yeah, okay. So let's start looking at this case here. We first start always looking at the sagittal T2 fat sat images, because that shows us the marrow edema and gives us a clue as to what is happening. Is this trauma? Is there degenerative osteoarthrosis? So, and also helps us looking at the menisci and ligaments too. So we are starting, this is the medial meniscus body, and you can clearly see fluid signal intensity. Let me zoom this up. Fluid signal intensity within the body of the medial meniscus. As we come further medially, you can clearly see it reaching articular surface, the inner inferior margin and the near the apex, the surface. So this is a horizontal cleavage tear, and you can see an associated parameniscal cyst here. And again, you can see this parameniscal cyst here. Whenever you have cyst very close relation to the meniscus, always trace them to that joining meniscus. This is the anterior horn of the medial meniscus. This is the posterior cruciate ligament, normal anterior cruciate ligament. This here is the posterior root of lateral meniscus. Somebody asked the question. So this is the posterior root of the lateral meniscus, anterior root of lateral meniscus, which normally shows this kind of striated bright appearance. That is normal. The posterior horn and the anterior horn of the lateral meniscus, which are normal. Now the same thing, I will look at it on a coronal image. On a coronal image, how do I see? I can again see a hyperintense signal splitting the meniscus into two. This is the small parameniscal cyst. And as I come anteriorly, I can see it is reaching the articular surface. So reaching the articular surface, it has to be an unequivocal and seen on at least more than a slice. You see sagittal images and coronal images. This is the normal body of the lateral meniscus, and the posterior root that somebody asked, this is the posterior root of the lateral meniscus. This is root of medial meniscus, posterior root. This is the lateral meniscus. So you'll see a defect there. This is the Popliteus tendon that I spoke about, this here. And these are the popliteomeniscal fascicles. So this one should not confuse with tear, because I can see it. I can see this is the tendon which is attaching to the femur here. And when I trace it to the other section, I can see it going down and becoming the popliteus muscle. This is the normal body of the two menisci, and this is the anterior root of the lateral meniscus. Let's look at another case. Again, we begin with sagittal T2 weighted image. And the first thing is what is kind of catching my eye here. This is the bow tie appearance, and then I don't see any bow tie at all in the second slice itself. That means some portion of the meniscus is missing. And also in the posterior horn, you can see this clear longitudinal tear like appearance. Here I can start seeing almost two anterior horn like appearance. And at this level, I'll just come to the other sequence. There's an ACL tear also. Let's look at non-fat sat sequence. That will be easier to make out. Yeah. So here I can start seeing the body. I see some piece out here. Something is abnormal, but I don't know what's happening. I look at it on coronal. Immediate next section, the bow tie is not seen well. The tear is extending into the anterior and posterior horns. And can you see this structure here? Here the posterior root should be small. This is looking like some flap here. This is the posterior cruciate ligament, and this is the anterior cruciate ligament. There is a tear. This is the lateral meniscus. This is the root of lateral meniscus. And you can see the lateral meniscus is normal. So now let's look at it on coronal image, what we saw on sagittal image. We are coming from posterior to anterior. What do we see? This is the posterior horn of the medial meniscus, posterior horn of the lateral meniscus. Can you see this here? Can you see this piece here? Normally we would not, this is PCL. Normally we would not see this whole piece here. So this is a flap which is here. And you can see this body is smaller. Look at this body of lateral meniscus, and here it is much smaller. And as you come anteriorly, can you see this flap here? So these are the common locations. The superior gutter, the inferior gutter out here. But remember, this is the meniscofemoral ligament. So always trace. Meniscofemoral ligament you'll see through and through, but this is only at one location. And the other common location is near the root attachment here. This, you can see this flap-like appearance here. And let's try to see the same thing on axial images. On the axial image, you can see this here. In the joint fluid, there is a structure. That's the displaced flap. And you can see this is the meniscus here, tear, and this is the flap here. So axials, it takes a little bit more of imagination to imagine what we are seeing on the sagittal and coronal images. This is the lateral meniscus. But we don't use axial because see, this portion is seen in this section, remaining is seen on other section. So you may not always find it in one section. So we do not use axial images for evaluating menisci primarily. We looked at the coronal images already. Let's look at this scan again. Let's try looking at the non-fat sat PD first. So this is the bow tie appearance lateral meniscus, about two sections. So that is fine, normal. Anterior horn, posterior horn, normal. Normal ACL, normal PCL. This here is the transverse meniscal ligament that I spoke about. Here you can see the structure here. This is anterior root of lateral meniscus, posterior root of lateral meniscus. You can see the structure here. It's coming all the way to other side and joining the anterior horn of medial meniscus. So this is the, so you should not get confused with a loose body or a meniscal tear. This is the posterior root of medial meniscus. It should be seen where the PCL is seen. You can see the structure here. So that's fine. And then here this medial meniscus does not look all right. This is normal anterior horn. This posterior horn does not look all right. Let's see that on the fat sat T2 weighted images. Can you see this tear here? This is abnormal. So now I'm going to look at it on the coronal image, because this tear is at the posterior horn body junction almost of the medial meniscus. Posterior horn of lateral meniscus, posterior horn of medial meniscus, and you can see this along the undersurface there is this defect. So this is an undersurface, an oblique tear. And as you come more further, can you see this flap here, a piece here? This is blunted, it's not triangle. There's a defect here, and that flap has come here at this location. So these flaps can be subtle, and we have to look for them very carefully. Let's look at another example. Okay. And the first thing which is catching my eye, normal bow tie appearance of medial meniscus, and just after one section it's gone. That means something is not right. And then I start seeing here. Can you see here? It looks like there are two anterior horns of the medial meniscus, and the posterior horn looks smaller. So posterior horn should be double the size of anterior horn, but here it's looking smaller. It looks like two anterior horn. And then can you see here? This looks like double PCL. This is the original PCL. And this looks like one more PCL. And all of these point towards bucket handle tear. This patient also has an ACL graft, and you can see this large cyclops lesion. You can see here, large anterior intercondylar nodule. We'll see on T2 images, again, same thing. There's no body seen. Barely it is seen in one section. No bow tie appearance. Posterior horn looks small. Anterior horn looks larger. Looks like two anterior horn. This is the original anterior horn. And this is looks like a double PCL, additional PCL. Graft, ACL repair, ACL reconstruction. And you can see that the graft is intact, but there's this large cyclops lesion. We confirm a bucket handle tear always on a coronal image. Coronal image, normal lateral meniscus, look at the medial meniscus. Can you see this small body and this large piece here? This is the normal body of lateral meniscus. Here, this body of medial meniscus is small, and you have this whole fragment in the intercondylar region. See this? So this is a red zone tear, and you have a large component in the intercondylar region, which then comes here to the anterior horn. So this is a bucket handle tear of the medial meniscus. And this here is the large cyclops lesion. This is how you would see on arthroscopy, a huge cyclops lesion. Let's look at this image. Lateral meniscus looks normal. There is a PCL avulsion fracture. But what we also see is this meniscus. Can you see the meniscus has a horizontal cleavage tear? Anterior horn of medial meniscus, posterior horn of medial meniscus. There's a clear cut horizontal cleavage place fitting the meniscus into superior and an inferior half. Same thing if we see here, this is the tear. So this tear here is splitting the meniscus into a superior and an inferior half. This is a horizontal cleavage tear of the body and posterior horn of medial meniscus. And also this patient has got cartilage loss. If we look here, we can see this intermediate signal intensity cartilage. And here you can see, this is the normal cartilage. And here you can see there is cartilage loss. And this is the horizontal cleavage tear. This is exactly what we call as a fish mouth tear. That's what this is looking like. Another example, let's look at these images. Okay. Sagittal PD images. I'm just showing the PD image before FATSAT T2 because anatomy is more better seen here. Bow tie looks fine. Posterior horn looks double the size of anterior horn. All look fine. Medial meniscus is normal. PCL normal. ACL there is a tear. And now when we come to lateral meniscus, so this is the ACL, okay? As we come here, we start seeing hypointensity, which we should not normally see. And when we go further, you can see this posterior horn of lateral meniscus is abnormal, and it looks like there are two anterior horns here. We are suspecting a bucket handle tear. I'll want to look at the coronal image before confirming it as one. This is the normal medial meniscus. This is the lateral meniscus. You can see this body here is smaller. There's a tear and this is a fragment out here. But this body is not very small. So maybe he had a partial discoid meniscus, but clearly there's a fragment out here and you can trace it all the way coming to anterior horn. You can see this fragment out here. Let's see how it is seen on the axial image. Maybe here the axial image can show it well. Yes, it is. Okay. This is the full medial meniscus, this black C-shaped structure. This is the lateral meniscus and this is the intercondylar component out here. Okay. This here is the intercondylar component for bucket handle tear. Let's look at this image. This medial meniscus surely does not look fine. There's marrow edema here, subchondral. Okay, so this posterior horn looks okay, and then you don't see any posterior horn. So maybe this is exactly what one may call as ghost sign appearance. I'll show you here. The medial meniscus, see, there's no meniscus. And then near the root it comes. Can you see here? There's no meniscus in this section. That is what is known as ghost sign. Why is it seen so? Because there's a radial tear. You can see this. This is the root here. The normal root of the meniscus should attach towards the tibia, while posterior horn, you can see it's not dipping to the meniscus. There's a root tear. And in addition, there is a degenerative oblique tear here also, but this is a root tear. Cartilage is maintained and the extrusion is minimal, not significant extrusion. This is a medial meniscal root tear. On the axial, how will I see it? This meniscus here is not attaching to the tibia. Let's look at the next case. I just thought few cases which we see normally. Medial meniscus looks normal, normal anterior horn, posterior horn. This is the root attachment, which is degenerated, but still it's reaching the level of PCL, so it is fine. We look at lateral meniscus and see what is abnormal. You see bow tie in too many sections. See, body of lateral meniscus, bow tie 1 section, 2 section, 3 section, 4 section, 5 section, 6 section. The bow tie is kind of not ending. And you have a tear and this parameniscal cyst. So I am suspecting a discoid meniscus. How do I confirm? Look at the coronal image. This is how body of a medial meniscus is. But here, can you see this is an incomplete discoid lateral meniscus. The meniscus is coming all the way till here and it has a tear within it and a large parameniscal cyst. All of this is a parameniscal cyst. Axial images, I can try to see the same thing. This is the parameniscal cyst going all the way here. Discoid meniscus, this is the normal medial meniscus. Here it is still here. So axial images are not very good because you may not see it in one section. This is a partial discoid lateral meniscus with a tear and parameniscal cyst. Let's look at this image. Lateral meniscus looks normal, normal anterior and posterior horns. ACL, there is a tear clearly. And medial meniscus shows intrasubstance degeneration. But as you come towards the root, there is no meniscus at all. Normally, root of the meniscus should be at this level where the PCL is there. So I'm looking at a root tear. How do I confirm it? This section shows it very well. See, this lateral meniscus goes all the way up to the tibia. So trace it. But look at this medial meniscus. There's a defect here. It's not going up to the tibia. This is a root tear of a medial meniscus. And then I look at this meniscus. It is degenerated. It shows intrasubstance degeneration and mild extrusion. Anteriorly, there's no extrusion. Posteriorly, there is very minimal extrusion. How do I see it on an axial image? Here, you can see this defect out here. But as I said, I would not really look at axial images. Look on sagittal and coronal images for tear. And I think this is the last case which I can show you today. maybe I'll show you, and if you could answer. 1 second, let me, maybe you can just put in the chat box what you think. I'll show you the better image. Okay, yes, this image. Yeah, unfortunately, I'm not able to see that. Okay, so if we just look at it, something very clearly catching our eye, there is a large depression here at the sulcus terminalis. So there is an impaction injury. Note, there is no posterior horn of lateral meniscus at all. And instead, this anterior horn looks all large and buckled up kind here anteriorly. There's literally no posterior horn, just this very small remnant out here. ACL is torn. Medial meniscus is normal. Posterior horn is larger than the anterior horn. Now we look at it on the coronal image. This is the normal medial meniscus. You can see it, normal medial meniscus. This patient also has MCL tear. I'm not going into those details. This is normal medial meniscus. But look at lateral horn, lateral meniscus. There's no posterior horn at all. There's hardly any body. The body is so small. But you see a anterior horn, and you see again something looks like anterior horn. On the axial images here in this patient, you can see it very well. This is normal medial meniscus. You can see this. Here, can you see this lateral meniscus has a bucket handle tear, and this whole fragment has flipped here. There's barely any meniscus. The whole meniscus has flipped anteriorly here into the intercondylar region and anterior. So important thing is to always look at the normal, be aware of the normal appearances. And when you're looking at sagittal and coronal images, to imagine how it would look in a three-dimensional picture. Any questions? Yeah, this was a bucket handle tear and flip. How do we assess extrusion? So if we draw a line along the peripheral margin of the medial femoral condyle and tibial plateau, and that's how you look for extrusion. You may give measurements to quantify it, or you may see it as, call it as mild, moderate, or severe. How to differentiate T2 fat sat and PD fat sat on imaging. So one thing is, on the film itself or on the sequence, it would be written at a corner which sequence it is always. Otherwise, we go by something called as TR and TE, which is going into physics, which is not needed. Fluid looks, or another way to look at it is, fluid looks very bright on T2, much more bright on T2. As compared to PD, it looks a little more bright. Tear pattern in second case, which was the second case that I showed, just a minute, with two flaps. Yeah, okay. So when there are two flaps, it could be that it could even be a transected bucket handle tear. When you have a transected bucket handle tear, you will have two flaps, one going anteriorly, one going posteriorly. Or sometimes there could be two parrot beak kind of tears, and you have two fragments. But anterior and posterior more often would be a transected bucket handle tear. Acute tear or a degenerative tear, yes. So a degenerative tear, the rest of the meniscus will show degeneration. Acute tear, we will know. So chronic tears, yes, because in chronic tear, the meniscus would have undergone attenuation. But otherwise, acute tear would be more because we are looking at other findings, like there is marrow edema, there is marrow contusions, which suggest acute pathology. The meniscal tear itself, which is acute or not, may not be possible to say. Okay. So the problem with MR is, in acute stages, MR overestimates the pathology because of all the edema and hemorrhage. And in chronic cases, it underestimates the pathology because there is no edema and sometimes structures remodel. Ligaments remodel, meniscal tears kind of are partially healed. So which underestimates. So do we wait for edema to settle? So there's no ideal time when you want to do an MR. Depending on what you are suspecting, what you are looking, you may want to do an early MR. You want to look for bony avulsions, you want to look for high-grade ligament tears. But what we should keep in mind is that yes, MR could be slightly overestimated. How to differentiate non-fat sat PD and non-fat sat T1? So T1 fluid is dark. PD fluid is slightly bright. When to repeat MRI if meniscus healing treated conservative? So again, there are no fixed kind of timings that usually one goes more by what you are feeling clinically and when do you want to follow up the patient, but not before 6 to 8 weeks, because what happens when you do the MR imaging appearance of healing lags behind the real healing. And that's true for everything, whether it be infection, whether it be trauma. In fact, marrow edema can remain for 3 months after the injury. So that's why any kind of follow-up, early follow-up does not help, because MR imaging healing lags behind the clinical healing. So I would say not before 6 to 8 weeks for sure. Weight-bearing MRI, unfortunately, we do not. The problem is 1.5 and 3 Tesla are the MR which give you good images. People came up with low field of strength, 0.2, 0.5, those kind of MRs, which could be more standing or weight-bearing for the spine. But the image quality is not good then to look for cartilage and meniscus. Can we decide healing of meniscus by comparing initial and later films? Yes, we can. We see what is the appearance, and like I said, T2 weighted image. Is it still bright on T2, or on T2 is it getting less bright? But it's not 100% for sure kind of thing. But yes, we can. Comparing with the earlier film always helps to see the interval change. Yes, so post-operative meniscal repair. One second. Do we have time? I can just try to see if the post-op meniscus image, if I want to show. Dr. Ashok, do we still have time?
Abhishek.
Yeah, we have time. Okay, fine. So let me just quickly, I'll just quickly search for this one image. I didn't include it because I thought it would, the timing would be quickly. Just give me a minute. I'm trying to search for a post-op meniscus. Yes, I found it. Okay. Yeah, I'll just share the image, share the screen. Yeah. So is this visible? Yeah. Okay. So this is how it looks post partial meniscectomy. This is the normal lateral meniscus and this is the medial meniscus. So because of that, what I discussed, how do we identify tear? By looking at abnormal morphology and by looking at abnormal signal. So here morphology is already altered. So that's one thing. Post meniscal repair, this is how it looks. So you can see this signal within the meniscus, and you can see on T2 weighted image, it is still bright. It looks like it's reaching the articular surface, but not as bright as fluid. So this is fluid here. You can see this bright signal is fluid. So this is after meniscal repair and it is fine because there is no displaced component, nothing else. This is normal post meniscal repair. Again, something like this. This is also still normal post meniscal repair because you can see this here. This is where it has been repaired. This little bit of defect like thing inferior here is fine. But you can see it's not fluid signal intensity. This is fluid. You don't have fluid signal intensity going into. So it's not re-tear. This is a meniscal repair. Here, again, this was post meniscal repair and something like this can get difficult. Now here it looks like almost fluid signal intensity going here. And these few times it can really get difficult and one would have to correlate with the clinical, are there meniscal signs or not. So this MR appearance can be really confusing. It can still be only post-op findings. This is clearly a re-tear. So this patient had undergone meniscal surgery, and now you can clearly see fluid signal intensity. When you see clear fluid signal intensity, compare that with this inside the meniscus. This is not fluid signal intensity. So that helps. But as I said, that may not be seen every time. So sometimes now something like this here. It's not very clearly fluid signal intensity, but it looks like reaching articular surface. But it's not fluid signal intensity. So probably this is how we'll reword the report, that it's a normal post-repair appearance, no displaced fragment or anything. But if you have strong meniscal sign, this could still be a tear. This is something where the clinical appearance, clinical findings would be important. Again, here, this is a post-operative appearance. And we have said, and we have found that there's no joint line symptoms, and there is not less likely to be re-tear. A new parameniscal cyst formation, again, is worrisome for a tear. Or if you have a new fragment. So now we can see this flap coming here, which was not there in the prior surgery, pre-op images. So that clearly tells you it's a re-tear. Again, this flap coming here tells you this is a re-tear. This is a root tear that had been done. This was the initial root tear. And this is follow-up after that. And in the follow-up, the cartilage loss had worsened. This was the root repair. And you can see the root is still bad. So even after the repair, this root was torn. In fact, the tear size has increased as well as the cartilage loss. Initially, the cartilage loss was lesser, but this had progressed. So yes, in post-op, at times it is difficult. We need to take into account the T2 fluid signal intensity. We look into the comparison with prior, what surgery was done. We need to know that. So when I trained at Singapore long time back, they used to do a lot of arthrograms in post-op cases. But in our practice, we do not do, and on routine images, we've been able to talk about the re-tears with fair confidence. But as I said, not all the time. There are times when it is more. Any findings related to calcified meniscus? More than calcified meniscus, we would look at meniscal ossicle. So we see it as a similar to bone-like appearance, a small ossicle. We have seen that sometimes in post-trauma. In fact, we have follow-up where the initial MR just shows tear and later a meniscal ossicle has been done. Do implants of ACL affect images of meniscus post-operatively? Usually not. The current ones which are used are usually do not cause much of an artifact. We do not have any problem. But there have been few instances when the ACL surgery has been done very, very long back, and depending on what kind of screws were used, the material, yes, there have been very few times when there has been significant artifact interfering with the visualization. But otherwise, most of the times, no. Okay, so I think that answers all the questions. If there are no other questions, thank you so much for inviting us here to be a part of this. And it's been good experience interacting with you all. So then could we end the meeting?
Thank you.